What's the difference between just a few sleepless nights and having a diagnosable case of insomnia? Many of us experience trouble sleeping, even me every once in a while, but insomnia itself can be debilitating. In this video, I'm going to tell you the number one telltale sign of insomnia, and it's probably not what you're thinking. Hey everyone, I'm Dr. Michael Breus, the sleep doctor. The symptoms of insomnia are some of the most common complaints that I hear from my patients. So I'm going to walk you through what I look for, as well as some of the ways that insomnia presents itself in clinic. Basically, insomnia is a complaint of either difficulty falling asleep, difficulty staying asleep, or general poor quality sleep. You can have one, two, or all three of those. Also, this complaint is oftentimes associated with some level of distress, so the person is definitely upset about it, and some level of impaired function. So they're not able to complete their job tasks or activities of daily living or things like that. We also see a slight increase in physiological arousal. You might be wondering, what do you mean by that? I mean, your biology for a lot of insomniacs is actually moving a lot faster than other people's biology. We know that your metabolic rate actually turns out to be increased, which means your whole system is moving faster, as well as something called sympathetic activation. So in our bodies, we have the autonomic nervous system, and that is broken out into the parasympathetic and the sympathetic systems. The sympathetic system is the one that's kind of fight or flight. That's the one that gives you a lot of energy. That turns out to be elevated in insomniacs just at the general level. What we really would prefer is parasympathetic activation, which unfortunately does not appear to be happening in a lot of insomniacs. We also see this very increased state of alertness. Now, this could be a conditioned state of what we call hyperarousal, meaning they're so used to not sleeping in that room in the back of the house, the second they walk into that room, whoosh, their anxiety goes up and they're very alert and wondering what's going to happen. Because of this level of alertness, we usually see what we call a decreased sleep efficiency. Sleep efficiency is a gross measure where we say, how much time in bed do you spend asleep? If you've got increased alertness, chances are that's going to increase. And we really don't want that to happen. We want to actually see your overall level of sleep increase instead of the level of alertness increase. Now, what's the prevalence of insomnia? Wow, it can range depending upon the demographic that you're talking about. But insomnia is the most common sleep complaint in the entire industrialized world. If we look at, let's say, just the US, complaints range somewhere in the 30 to 40% of the entire population at any given time. And with the complaint of it being distressful or chronic, somewhere between 8 and maybe 10 to 12% of the time. So what we're looking at here is high levels of prevalence and a lot of different types of complaints. Now, one of the things that we know is most insomniacs underreport their sleep problem to physicians. We actually call it a door handle diagnosis. And what we mean by that, it's like right when the doctor's got their hand on the door to leave, the patient from behind says, "Hey doc, I'm not sleeping so well." And the doctor then, a lot of times, is not in the mood to ask this question, might pull out a prescription pad, hand them a pill, and send them on their way. That's really not what we're looking for. So we looked at the research, and in a 1998 study, we found that 69% of physicians never discuss sleep at all. Only 26% discuss sleeping the visit for other purposes, and very few physicians actually started asking to discuss sleep problems, likely around 5%. So this may or may not be something that your doctor wants to bring up, but it is something that you should bring up with your doctor. So what could be some of the risk factors that you're looking for? One thing I'll tell you is, in my 25 years of experience, almost every patient that I've had that has insomnia that isn't for a specific reason usually has a family history. Oftentimes it's mom, but sometimes it's dad. Somebody in the extended family was always up at night. It's often very comical because I'll talk to somebody and I'll say, "Well, tell me about your parents' sleep or the home that you grew up in sleep." And they, "Oh, my mom or my dad, it wouldn't matter what time of the night, they were up wandering around," things like that. So oftentimes I hear that. We also start to see this happening as age increases. So as we're moving up the scale of age, we definitely start to see insomnia become more and more prevalent. The question becomes why? Is it physiology? Is it because as we age, our sleep stages get a little bit different and they're not as deep and things like that? Possibly. Could it be due to increased medical problems as we get older? That could have something to do with it. Could it have to do with medications that we're now taking? That could have something to do with it. So As we increase in our age, we definitely know that sleep problems get a little bit worse, and insomnia in particular is one of the things we want to look out for. Now, one thing that's really interesting was a study that was done not that long ago looking at women presenting to sleep clinics. What they discovered was that a lot of women that are presenting to sleep clinics don't want to say that they snore, so they come in with a complaint of insomnia when in fact they might actually have sleep apnea. Well, it's kind of interesting because when you look across genders, women, generally speaking, have more insomnia anyway. So it's very difficult sometimes to sort of tease these things out. So when you're a physician and you're looking at a patient and you're trying to understand what's going on, in many cases, the female gender might lead you to potentially a diagnosis of insomnia. Another big factor are psychiatric symptoms and disorders. I gotta be honest with you, almost everybody that has a mental health situation probably has some level of sleep issue. We see this a tremendous amount in anxiety, depression, but also in the more complicated mental health situations. Almost always there's some sort of sleep component, whether it's nightmares, difficulty falling asleep, or in some cases, sleeping too much. And then, of course, the final area is medical symptoms and medical disorders, and of course, medication. So as we get more medically complicated and more stuff is going on in the body, that's gonna have a big effect and increase the likelihood or risk factor probably for your insomnia. By the way, we have a ton of information about insomnia on our YouTube channel, so be sure to hit subscribe. You probably know most of the things that I've been talking about, and I said there's one thing that you're probably not thinking about. Well, most people, when they think about their sleep, they think about what's going on at night. I want you to start to notice what's happening during the daytime, because if we can catch your daytime functions that are going off earlier, we might be able to help you with insomnia. But now you're saying, well, Michael, what are my daytime complaints of insomnia? What are things that are going on during the day that are actually being caused by my lack of sleep at night? Well, one thing that seems pretty obvious, it might be fatigue, sluggishness, or sleepiness, right? Okay, I'm tired during the day because I didn't get great sleep last night. But there are also things like somatic complaints, also stress about sleep. I can't count the number of insomniacs that come to me and they say, I am so stressed out about my sleep. And we know stress, like anxiety, is not good for sleep. Mood disturbances. A lot of people have very irregular moods because of sleep at night, and they never think to tie the two together, as well as poor concentration, even impaired performance during the daytime. So when you start to think about risk factors for insomnia, there's also medical risk factors that a lot of people don't think about. One of the biggest ones that I always like to talk about is pain. A lot of people really don't think about it because most people who have severe pain might be taking some type of analgesic or something that's helping them with their pain. But in fact, most of my pain patients have got some form of sleep or sleep disorders that's going on. Other things that we see is people who are in general poor health. Absolutely, they've got insomnia. But here's an interesting one, migraine. I've seen a lot of patients with migraine who have secondary insomnia. By the way, one of the things that we found that can be kind of helpful in that is if we find that they have a magnesium deficiency and insomnia with migraine, oftentimes when we supplement with magnesium, it actually helps the migraine, which then helps the sleep. One area of medicine that people don't think about with insomnia, usually think about it with sleep apnea, is diabetes. We know that a lot of people with diabetes do have sleep apnea. There's also a ton of those folks that have insomnia on top of their sleep apnea. So we really have to be thinking through, okay, what kind of patient do I have in front of me? They might not be complaining of insomnia, but they might just think, well, I've got diabetes, so I must have insomnia as well. Or I've got pain, so I must have insomnia as well. It's not necessarily the case, and there are ways that we can get through this in terms of treatment and be able to help them with some of those other medical disorders that can, in fact, help their sleep. Let's say I've got a patient in front of me, and I want to describe to them how we think the process of insomnia actually began. So what I like to do is I like to explain to everyone what I call the evolution of insomnia. So most of my insomnia patients, not all of them, but I gotta be honest with you, I'd say about 90%, they have an initial higher level of anxiety. For whatever reason, we call this a predisposing factor. Maybe it's their genetics, maybe they're just, an anxious person, but they've got a higher level of anxiety than, let's say, the general public. Then something happens, okay? We call this a precipitating event. Could be a stressful event in the positive, could be a stressful event in the negative. Let's take a negative event because it'll make for an easier story. So let's say that the person is getting involved in a divorce. Well, that's a pretty stressful situation. Makes a lot of sense why you would raise above that insomnia threshold of anxiety and not be able to sleep. But here's the thing. is whatever that event is, it usually goes away over time. Like a divorce only seems to happen right at the moment and you're signing the papers and you're doing all of these different things. And so that level of stress should begin to come down. It probably doesn't go down all the way to the initial bottom, but it stays low enough where it's underneath that insomnia threshold. But every time you're reminded of that situation, like when you have to pay alimony or child support, guess what? The stress comes back up again, and now you've crossed the threshold, and now you're having more insomnia. So as you can see, you have this genetic component, then an event. The event happens and comes down, and then there's something that seems to perpetuate this level of anxiety and keeps it going. That's really the area that we're trying to focus in on and bring people below that insomnia threshold. We also know from a clinical presentation, there's a lot of other things that insomnia could be secondary to. So in some cases, we know insomnia is primary. That's the thing that's going on, affecting other stuff. But in some cases, it's secondary, and we have got to really make sure that we're treating that secondary medical condition. In the chronic pain universe, that's fibromyalgia and arthritis. In the respiratory world, that's COPD and asthma. When you're looking at things like cardiovascular, we're looking at things like congestive heart failure, angina, but gastrointestinal also is a really big area that seems to have a lot of effect on people sleeping, specifically gastroesophageal reflux disease and IBS, or irritable bowel syndrome. From a gynecologic standpoint, we know that PMDD can definitely cause some sleep-related issues, as well as pregnancy and menopause. And then, of course, on the infection side of things, if you get encephalitis, HIV, insomnia would be secondary to those medical conditions. Now, you can also have insomnia secondary to psychiatric conditions, which makes a lot of sense. Some people used to think that insomnia was merely caused from an anxiety disorder or a mood disorder. We now know that that's actually not true, but they can be secondary to one another. So what happens? Well, if you're somebody who's been diagnosed with something called generalized anxiety disorder, or GAD, these are people who oftentimes have got low-level insomnia. If you've got panic disorder, where you have panic attacks can come in the middle of the night, which can cause insomnia. If you've got obsessive compulsive disorder, or PTSD, your obsessions may force you to get up and check things often, or your PTSD may actually have nightmares and things of that nature. Mood disorders turn out to be a really big one as well. Bipolar disorder, major depression, even something called dysthymia, which is a low level of depression. Of course, things like psychosis and substance abuse disorders are very prevalent, and those almost exclusively have insomnia with them as well. I want to double tap for just a second on insomnia and depression because it's so prevalent. We have a tendency to see insomnia in depressive patients anywhere from 50 to 95% of the time. So we really want to take a look at how is sleep affecting this ability to stay depressed or to stay out of that level of depression. We know that it impairs your quality of life. We know that it impairs your response to depression therapy, that being insomnia. And we know that insomnia increases the risk of depression. We actually have seen a recurrence of suicidality in patients who've got higher levels of insomnia. So we really do know that insomnia and depression are linked. And so if you've got one, there's a very high chance you've got another one. And treating on the opposite side of that, so treating the depression sometimes can help with the insomnia, and treating the insomnia can sometimes help the depression. Also, medications can cause insomnia, and a lot of people don't even know about it. One of the biggest culprits is those analgesics with caffeine. So if you've ever seen the migraine medicine that really helps get that migraine and it's super strength, look on the label. Almost every time it's an analgesic or a pain relief type of medication or compound with caffeine to make it go faster. Well, guess what? The caffeine is not going to help you when it comes to sleep. Antidepressants. There are some antidepressants that we use in clinic for patients with narcolepsy because they're so stimulating. So sometimes just talking with your psychiatrist and saying, hey, can I take my antidepressant in the morning instead of in the evening time, can actually solve all kinds of problems. Other things, believe it or not, and this is a weird one, opiates. So withdrawal from opiates and withdrawal from almost any form of drug addiction usually leads to a pretty significant level of insomnia. I want to describe to you what I think, or what the model is for what's going on in your head when all of this is going on, right? Because I've given a lot of information so far today, and I want to kind of put it into a little bit more of a comprehensive model. So number one, you start off with either difficulty falling asleep or maintaining sleep or just having poor quality sleep. When you wake up, you get pretty frustrated, and you even get frustrated in the middle of the night. I mean, I hear it from my patients all the time. Then that frustration seems to turn at some point to fear of not being able to fall asleep, like ever. And I gotta be honest with you, when you're sleep deprived and it's the middle of the night, your brain goes wild and comes up with all these crazy things that are gonna happen to you if you don't fall asleep. While your brain is doing that, it's causing a level of physiologic activation. Your heart's beating faster because you're like, oh crap, I'm gonna be doomed tomorrow if I don't fall asleep. Elevates that level of sympathetic nervous system like we were talking about before, which is not good for sleep. Then your behavior and your thoughts go sideways and you think to yourself, I'm never gonna be able to get to sleep. And you start thinking in the wrong way, which makes it difficult to fall asleep again. And now we've got this circular model of what's going on inside your head. So the goal here is to figure out how do we break this cycle of insomnia. Step number one is usually showing up at somebody like my office where we do a full assessment and diagnosis of your symptoms. So we're gonna sit down and we're gonna spend probably 45 minutes to an hour, ask you a long sleep history. How did you sleep when you were young, middle, now, medications, medical, all the stuff that you would think about in an intake. And hopefully you get some level of diagnosis. At that point, almost everybody across the board is going to begin to educate you about insomnia. You're gonna get education on what it is, how it works, somewhat similar to what you've been learning here today, including understanding what we call good sleep hygiene. Now, hygiene always makes me think of things being clean or things being dirty. That's not what we're talking about here. What we're talking about is basically good sleep habits. And almost everybody out there is gonna be able to turn to you and give you some information about that. Here, though, is where things seem to change and patients seem to choose different pathways. One pathway is to choose something that's pharmacologic, some type of medication that they can take to either break the cycle of insomnia or to get on and stay on for extended period of time. Then there's a second path. The second path is non-pharmacologic, and this has to do with things like cognitive behavioral therapy, sleep hygiene, a few other behaviors, maybe even some supplements. I'll have one video that's gonna talk all about pharmacology therapy, and then we'll have another one that talks all about non-pharmacology therapy. I know insomnia symptoms can be incredibly disruptive, so if you suspect that you have insomnia, contact a physician right away. They can offer a great path to better sleep. This is Dr. Michael Breus, the Sleep Doctor, wishing you sweet dreams.